Yeah, I'll click because I'm going to try to fly through some of the slides so I can do it. So really my objectives today are to summarize the data related to PrEP use. Let me get to there. Identify who's going to benefit from PrEP and also discuss the clinical aspects, which we've already done a little bit so far. So about 1.1 million people in the US living with HIV currently. This is over the age of 13. And about 40,000 new infections, just to recap, each year. In West Virginia, this is a breakdown. So overall, West Virginia's prevalence is pretty low, less than 2,000 people living with HIV, and our population is about 1.8 million in West Virginia. So this chart is really just breaking down kind of the more concentrated areas, counties that have a little bit more HIV, but again, prevalence overall is still pretty low. The one comment I want to make about this is Cabell County. So I'm not sure if everybody's aware of the Cabell County cluster, but that is a population where HIV new infections, particularly in people who inject drugs, has increased just over the past year. So typically Cabell County averages about 8 new infections HIV every year, and since January of 2018, they've had 44 new cases, and these are all people who inject.
Up to 46.
Up to 46 now. Okay. You know what? I just looked at this on the 28th, so it's already, or 28th of April. So well,
it's it's still such an active investigation that I'm sure that 46 will not be a final number either.
And so they're still classifying this as a cluster because it really is just within the injecting drug use risk factor, but they haven't classified it as an outbreak yet because it's not transferred into other risks. But that's definitely something to be concerned about, is this is real. And so that gives us more evidence that we need to be starting to be more mindful about implementing preventative measures for HIV transmission. So in West Virginia, this is just a breakdown. So overall, still male-to-male sexual contact is still the highest transmission population within West Virginia, and women it's heterosexual contact. Wow. But again, injection drug use is on the rise, as we discuss pretty frequently at the ECHO. So the concept of PrEP, kind of my analogy to patients is I kind of discuss with them, it's the concept of birth control is for pregnancy prevention. So this is a pill that you take once a day if you're at high risk of HIV infection, so basically before you have a potential exposure. And kind of that approach, people are like, oh, okay, that makes sense, and they might maybe a little bit more on board with taking it. So in July of 2012 was when the FDA approved Truvada, which is the brand name. It's the only medication that's approved right now for PrEP. 2 NRTIs, originally approved in 2004 for HIV treatment as a partial antiretroviral regimen. It's a co-formulated tablet. You take once a day of emtricitabine and tenofovir disoproxil. You take it with or without food. And it's really been shown so far that it really should be taken once a day in order to maintain active drug levels for HIV prevention. So in 2014, PrEP clinical practice guidelines were issued by DHHS and CDC, and those were actually updated in 2017. It's, again, recommended as one prevention option for sexually active adult MSM, or men who have sex with men, adult heterosexually active women and men, and adult persons who inject drugs who are at substantial risk of HIV acquisition. And we'll talk more about what classifies as substantial risk. The FDA just recently approved Truvada for PrEP in adolescents that weigh over 35 kilos, and that should be released with a new CDC guidance, the next update, but it's not yet. And it's the same risk factors that it's indicated for. So this is a slide with all of the trials that PrEP efficacy has been evaluated in. I have it broken down between the MSM trials, men and women, heterosexual, and then those who inject drugs. So lots of data, has been formulated about PrEP. And basically what this has shown is that drug levels correlate with a protective effect. So the Partners PrEP trial, this was for heterosexual men and women. It was a large population. It really showed overall those who took PrEP had about a 75% overall HIV risk reduction, which sounds okay, not, you know, great, but better than nothing. But then when they look back to see those who had detectable drug levels, it was really up to a 90% risk reduction. Similar was the IPREX trial, which looked at MSM, and then also a small proportion of transgender women. A 44% overall risk reduction, which is but then again, a 92% risk reduction in patients that had detectable drug levels. So truly, adherence is really key for PrEP. I didn't have enough room on the slide, but I do want to mention, just because of the injection drug use, you know, risk factor within West Virginia, the Bangkok trial was done focusing on injection drug use, and it was about a 45% efficacy, and then still about a 75% efficacy with detectable drug levels, but they only used TDF. They didn't use the co-formulation, so it may have been higher if they had used the co-formulated tablet of Truvada.
Turn right onto Stadium Drive.
Oh, somebody's trying to call. Also, I want to point out that after the IPREX study came out, there was a strand trial that was done using a subset of MSM within the IPREX trial, and it actually looked at directly observed therapy, and they measured the tenofovir concentrations in those that had directly observed therapy, and this is MSM, and it really correlated that it was a 99% risk reduction if they were taking it, so 100% adherence, 7 doses a week, a 96% risk reduction if even taking only 4 doses a week, 76% if they only took 2 doses a week. So it's still very highly correlated with adherence, but there is some forgiveness with not perfect adherence. The other big thing I want to point out with that is this was MSM, so there have also been lab studies done that really looked at drug concentration levels in local tissue, like rectal tissue and lower vaginal tract tissue, and it's really shown that in women or in lower vaginal tract tissue, you really have to have 6 to 7 doses a week to have detectable drug levels at that tissue site. So even though there may be some more forgiveness for non-perfect compliance with MSM, with females, they really have to have consistent adherence. So how do we prescribe PrEP? This slide looks really funny when I pull it up on here. It was pretty on my computer. So this is a table straight from the CDC guidance, recommended indications for PrEP use by MSM. This is really a guide, but basically you have to verify they don't have any established HIV infection. So you can't start PrEP if they have HIV infection, or you're going to be giving them a partial HIV treatment regimen, and they have the chance of developing resistance. In men who have sex with men, if they've had any male sex partner in the last 6 months, and they're not in a monogamous relationship with a recently tested HIV-negative man, and then also have had any anal sex without a condom in the last 6 months, or have had a bacterial STI in the last 6 months, then they could be a candidate for PrEP. It also talks about if they've had a high number of sex partners, and they really classify that as 5 or more partners in the last 6 months, or if you have a patient that's a commercial sex worker, they may benefit from PrEP. For heterosexual men and women, it's kind of similar. You know, if they are not in a monogamous relationship with a recently tested HIV-negative partner, it does note if they have infrequent condom use. So really, I just say, you know, how often are you using condoms? Give me a percentage. And they've had more than one partner of unknown HIV status, then they may benefit from PrEP. Otherwise, it's pretty similar. What's kind of not listed on here is what to do if you have a patient who has an HIV positive partner. Carolyn talked about the U=U prevention campaign the last time we had HIV ECHO. So basically, if somebody comes into you and they have an HIV positive partner, and they're asking you about PrEP, or you want to talk about PrEP, the biggest thing is just asking them, hey, is your partner on treatment and undetectable? Has your partner, are they in care? Are they on antiretrovirals? Have they been undetectable in the last 6 months? unless they can say yes for sure with confidence, or if they have their partner with them, they may benefit from PrEP. And because I do have some patients that they're not sure, or they're in monogamous relationship, but then they're still getting an STI, so their partner's probably not monogamous. So I mean, just kind of weighing those risk factors, but really this isn't really indicated for somebody who has an HIV positive partner that's being treated and undetectable. For those who inject drugs, Greg, you'd mentioned earlier about, I really like your approach. I think it's perfect on what to do with people that are in newly recovery, or just, kind of, honestly, I kind of feel like if they're in the first 6 months of recovery is really the highest likelihood that they're going to relapse. I think if you're, especially with, Jen, now that you're in this, have the Suboxone clinic like right next to you, this is really something that's going to be very applicable to your practice. So I think, when these patients first come into care with you, just say, hey, have you ever heard of PrEP? And then if they haven't, kind of just explain to them, this is what it's for, just kind of to lay the ground that, hey, this is something that's available to you as a resource. I don't think it's a bad idea if they're, even if they're in recovery and they feel like they're doing great, because Greg made great points, like, they get this euphoria that they're not going to relapse, and then, or they might say down the line, hey, I relapsed once, but it was no big deal. So, they may benefit from it. You can always stop it. It's not something that was ever intended to be on lifelong. So I'd rather, get them worked up, get them started on it, and then stop it once they don't really have any risks anymore. So again, you have to have a documented HIV-negative test, and really the guidance says within 1 week of initiating PrEP. Ideally a combined antigen antibody test, and then really assessing at that clinic visit that they have no signs or symptoms of acute HIV infection over the last month. That they have normal renal function greater than 60 milliliters a minute of creatinine clearance, and then also making sure that you have their Hep B status documented. So tenofovir treats Hep B infection. So it's not a contraindication to start PrEP in somebody that has Hep B, but just understand that if they do have active Hep B infection and they start PrEP, you're also treating their Hep B. So when they decide to come off of PrEP, or if they're not adherent with PrEP, you're going to cause their Hep B to flare. Or they have the potential for that to flare. And then certainly vaccinate them if they're susceptible to Hep B. This is a testing algorithm. I just put this on here just as a quick reference for you guys. It's not something we have to go through today. And then, again, making sure that they're going to be committed to taking this every day. They should be coming in for lab testing and follow-up at least every 3 months. And at those visits, you're going to be doing STI screening, HIV screening. I don't give anybody a prescription for more than 90-day supply. I tell them you have to have an HIV-negative test before I can fill this for you again. And even if they can't make their clinic visit right at that 3-month mark, I tell them they at least need to go get those labs done. And then Hep C screening, particularly MSM in people who inject, I'd say at least annually. STI screening, the guidance really says you should be doing 3-site testing. So you could do a urine, urethral swab, vaginal swab, or pharyngeal or rectal. I usually do a urine, and then I tell the patient, hey, do you think I need to swab your throat and your rectum too? And I don't get turned down very often. They say, go ahead and swab all 3 sites, because we do find gonorrhea and chlamydia, not frequently, but enough when the urine is negative that I go ahead and swab 3 sites. Pregnancy screen and contraception for women who don't wish to become pregnant. And then also counseling on side effects. So most common side effects of PrEP are going to dissipate within the first month if they have any. It's usually nausea, headache, belly pain, sometimes appetite and weight loss. So really GI effects, but just kind of provide them reassurance that those are expected and that they'll get better within the first month. We talked about the creatinine clearance. The other note with PrEP is that tenofovir has been associated with a small but still significant loss in bone mineral density. So it doesn't mean you have to do DEXA scans on everybody before you start PrEP. but just kind of understand if they've got a history of osteoporosis, osteopenia, pathologic fractures, you may want to get that prior, and might also want to weigh that risk or benefit. But the studies also show that once they stopped PrEP, that loss was reversible, and it's like 1 to 2%. Making sure their immunizations are up to date. Drug interactions, there's really not many except Hep C meds. So a lot of the Hep C meds interact with the tenofovir. So just keep that in mind too before you start on Hep C treatment. And then again, just remember that discontinuation is expected. So patients will sometimes come in and just say, hey, you know, I'm in a long-term relationship now, I don't want to use PrEP anymore. And that's fine. That's the purpose of it. It's not supposed to be lifelong. This is just a summary table. Again, just for your resource. And then the only thing about this slide I wanted to mention was on-demand PrEP. So there have been some studies. There was a French study that came out that showed, you know, men that are they consider like a seasonal risk. So for instance, going out on vacation and know that they're going to have a lot of sexual partners, that on-demand PrEP may be of use to where they don't really have a lot of sexual risk, but in some instances they might. And so that concept's not recommended per CDC or FDA, but the ISUSA does do that as an optional recommendation. And it's really pericoital timing. So like you take a dose within 24 hours of having sex, and then you take a couple doses the few days after. It's just hard to be compliant with that, which is why it's not really mainstream. And just a comment again that, you know, PrEP, it's not 100% effective. It was never intended to be, neither is birth control, but it's highly protective, and it's intended as one option of a comprehensive HIV prevention package. So the 3 ways you can get resistance while on PrEP: if you start somebody on it and they were already acutely HIV infected and you didn't catch it, if they weren't adherent and got exposed to HIV during one of their non-compliant periods, or if the virus that they were challenged with was already resistant to the 2 components of PrEP. These are some challenges that we face a lot, and just encouraging you guys to, I don't know why this won't run further. To use PrEP. And that's it.
Awesome, thank you, Keely. Do you guys have any questions? I know we're cutting it close, but that's okay.
Sorry, guys.
No, not you.
I just have one quick question. This is Jen. That was great. Thank you so much. And do you have a slide or a table you could send about the drug interactions you said with Hep C, PrEP with Hep C drugs?
Yeah. So Harvoni would, yeah, it's in the, it would be in the guidelines, and but yeah, I can send out a table. But Harvoni interacts with the tenofovir. The other thing I would say is just if you have someone that's already on some nephrotoxic medications, just to probably monitor the creatinine clearance a little bit closer.
Gotcha. Thank you so much.
Yeah, Jennifer, there's on that HCVguidelines.org, which is like our Bible for you know, up-to-date HCV information. One of the topics is for HIV co-infected patients, and you can, it goes through. There's a table that looks at, because I don't have it memorized either. It shows tenofovir interaction with all the Hep C drugs, and
okay, great.
It does weird stuff for each different drug, so some of them matter.
Okay, I'll take a look at that. Thank you.
Thanks, Kelly. That was great. I mean, this is important enough and complicated enough that, you know, I think we should certainly say, send us cases about PrEP patients that raise questions. And, you know, it's probably worth going over some of this stuff again. Because it's not as, you know, it's not so pat. And while we do know that PrEP works terrifically well for sexual transmission, we don't really have the same database for acquisition through blood from, you know, from injecting. The study in Bangkok, you know, you can't ever tease out what component, what proportion of people's risk is sexual and is injecting among people who inject drugs. So it's a much more complicated situation. And typically the concentration of virus in blood is higher than the concentration of virus in genital secretions. That's really true when people are acutely and newly and acutely infected, when their HIV viral load will easily be in the millions. So we hope that it will work as well. And of course, people who inject drugs have sex too. So just understand it doesn't have quite the same level of solidity that you would ideally like. But I mean, I think we're open to reviewing cases because this really does come up.
Right. Any cases that you think are pertinent or anything related, obviously, go ahead, send them in. You can always put them in like that additional questions box if you don't want to click all the other boxes, or if you don't have to, just a question. That's no problem. Dr. Rexford, did you have a question? Did you comment?
Well, I was going to ask, I mean, you touched on, Kaylee, about resistance to the components of the PrEP. Is that a real thing, or is it more theoretical, and, you know, are we inducing it?
It is a real thing. So, I mean, they're definitely, and I feel like anytime that there's a PrEP failure, it tends to get a lot of press. And so it always, you know, poses this big scare, like, oh, PrEP doesn't work, it doesn't work. It wasn't intended to be 100%. And so really discussing with the patients, yes, there is a real risk of resistance developing. You know, again, that's why it should be used as part of a comprehensive package. So still discussing harm reduction, absolutely 100%. And then also saying that, you know, this is really a good tool to assist in reducing your risk of HIV, but it's not the same as abstinence, and it's not the same as just, you know, removing all that risk, period. So it really needs to be utilized with condoms, because it doesn't protect against STIs or pregnancy. It needs to be used as part of, you know, making sure that your clean works and really not sharing injecting equipment. But resistance does happen. A lot of the resistance cases, when they look back, they show it was actually that people were already acutely HIV infected before starting PrEP. So that thus they did. But there have been cases too where they did develop resistance on PrEP. It doesn't happen often, but it can, sure.
But it's pretty unusual.
It's very
the
unusual.
statistics I've heard is about, you know, it differs around the world, but tenofovir resistance I've read is about 1%.
Yeah.
You know, it's an identifiable mutation, K65R, you know, maybe 1%. The lamivudine resistance component, or amtricitamine component, maybe 10%. But combined, I've heard the quote of 1%. And that's what I quote patients. I'm like, there's about a 1% chance you might come in contact with the virus, blah, blah, blah. So
that's why I say they have to be really committed to being adherent to it, or else, you know, if they're with that virus and that medication isn't adequate in their bloodstream, they're not gonna, you know, they can develop HIV, sure, and resistance. But it's low. It doesn't happen often. The one thing I wanted to say to you just before we get off of here is just, I've had questions like, how long do I need to take PrEP before it's gonna work? Which I think is a good patient. I get frequently from questions from patients. So about 7 days if their risk is MSM. So about 7 days, you know, before they've got adequate protective levels. For bloodstream serum levels and vaginal levels, it's really closer to 20 days. So let's just take in PrEP and think that they're automatically safe.
Awesome.
Thank you, guys.
Is this okay?
Well,
that one patient of mine was funny. He